So for patients with VHL disease, we look at the patient and see whether or not they end up having multiple lesions that are threatening and would require an intervention. So this would include kidney tumors that would be up to or greater than 3 centimeters, hemangioblastomas that look like they're beginning to potentially cause neurological problems, or pancreatic neuroendocrine tumors that are approaching 3 centimeters in size. And in general, if we have a patient that has only one lesion, for example, one spot in the kidney, where an intervention with an ablation or a surgery would allow them to then have a long period of time where they would not need additional interventions, we would not offer Belzutifan to them. We typically are offering Belzutifan to patients who have multiple lesions that look like they're going to cause problems and would result in them having multiple surgeries. So we start Belzutifan on those individuals. We then follow them for the toxicities. The major toxicities include anemia, and the reason they get anemia is because erythropoietin, or EPO, is a HIF2 alpha client gene. So we're basically knocking down transcription of EPO. We, in my practice, typically are using erythropoietin stimulating agents to bring up the hemoglobin levels. The second major toxicity is hypoxia, which we don't see very often in patients with VHL disease when they're younger, but we do see it in older VHL disease patients and also in patients with advanced kidney cancer. There, what we do is we will follow. We ask every patient to get a pulse oximeter. We have them watch their oxygen levels. If it goes below 90%, we have them hold the drug. We wait till it goes above 92% and then have them lower the dose. The third side effect is the fatigue, and that is something that we manage usually with dose reduction.
I have a question. Why the Belzutifan is not so good for the PGL patients?
We do see shrinkage in pheochromocytomas, and I have less experience with PGL, so I don't have an answer to that question.
Yeah, in Chinese data, it's not so good, but in RCC, brain, air is so good.
So are these VHL-related PGLs? Or, yeah. So I don't know, and that's very interesting.
So my team collects the specimens for PGL, and we do some research. Why? We want to explain why the Belzutifan is not so good in PGL.
So probably there might be additional mutations on top of VHL that are driving the biology of the disease.
Yeah.
Very interesting.
Yeah.
This question is of great significance. In the field of advanced renal cancer treatment, there are already numerous drugs available, whether it is the guidelines issued by the EAU or a UA, the first line, second line, and even later line treatment regimens for advanced renal cancer are widely known and applied. In clinical practice, abundant reference evidence has also been accumulated for the treatment of clear cell renal cell carcinoma and non-clear cell renal cell carcinoma. However, based on the data obtained so far, Belzutifan has demonstrated exciting efficacy in the treatment of clear cell renal cell carcinoma, especially advanced clear cell renal cell carcinoma. Therefore, I personally believe that it will inaugurate a new era in the field of advanced renal cancer treatment. At present, the guidelines may classify it as a second-line treatment option, but with the continuous accumulation of clinical experience and the verification of more data, the status and role of Belzutifan in the treatment of advanced renal cancer will become increasingly prominent. Judging from the Chinese data of the LIGHTSPARK 015 study, the performance of Belzutifan is pleasantly surprising. In terms of safety, adverse reactions such as anemia, fatigue, and hypoxia caused by it are generally within a controllable range, indicating good safety. During the treatment process, we need to form a MDT and collaborate with internists to provide patients with standardized treatment throughout the whole process. Therefore, I firmly believe that Belzutifan is expected to become a powerful weapon in the treatment of advanced renal cancer in the future. As for whether the combination of immunotherapy will become a new direction in the future and whether the combination of belzutifan and immunotherapy can bring better efficacy, it still needs further exploration and verification. Therefore, I had an in-depth discussion with Professor Eric Jonasch on this matter. The two institutions plan to carry out further cooperative research, hoping to bring new breakthroughs and surprises to this field through our joint efforts.
Yeah, so the approval of belzutifan in advanced renal cell carcinoma clearly is a great advance for patients with renal cell carcinoma. This study looked at individuals who had received prior therapy, either with an IO agent plus a TKI. They had to have received both. And the median number of treatments that the patients had received was 3. What we saw with that study was the objective response rate was around 23%. But the other thing that we did see was that the progressive disease as best response was 34%. So clearly some people are benefiting, but others not. If patients responded, the responses are close to 2 years, and the treatment is very well tolerated. So I see the future for belzutifan in advanced renal cell carcinoma as being a monotherapy in individuals who have received prior treatments. But the big question is whether or not belzutifan should be combined with other therapies in earlier lines of treatment. We have data from LIGHTSPARK-003 that shows that in combination with cabozantinib, there's an objective response rate of around 70% and a progression-free survival of 30 months in a predominantly favorable risk population. So maybe combination with cabozantinib is a good idea. We have a number of other studies combining belzutifan with IO therapies and IO TKIs, and we don't have information on those yet. For example, there's also a study of belzutifan plus lenvatinib compared to cabozantinib, that's LIGHTSPARK-11, and we're waiting those data. We do have a few data on belzutifan with IO therapy. There are the Keymaker studies that are being run right now. Very small numbers, but show that belzutifan together with immune therapy does not seem to have quite the same progression-free survival as belzutifan with a TKI. So maybe there is less synergy or additivity between belzutifan plus immune therapy compared to TKIs. I think we need to keep on working very hard on understanding how to use this drug. It's clearly helpful, and which combinations are going to be best and in which disease state to use, we will find out in the next few years.